Hello, and welcome to this episode of In Discussion With from PharmacyUpdateOnline. Today, I'm talking to Professor Cathy Harrison, Chief Pharmaceutical Officer for Northern Ireland. And we're talking about implementing innovative clinical pharmacy services across a whole health system. Could you start by introducing yourself?
Hello, my name is Professor Cathy Harrison. I'm the Chief Pharmaceutical Officer at the Department of Health in Northern Ireland.
And can you give us a brief overview of your role, what your current job involves?
I am one of 4 Chief Pharmaceutical Officers in the UK. We have one in England, Scotland, Wales, and Northern Ireland. And in my role, I am the most senior advisor to government on pharmaceutical matters and also the head of the pharmacy profession in Northern Ireland. And I have responsibility for medicines policy, and that includes pharmacy practice, medicines access, medicine safety, innovation, e-pharmacy, and pharmacy workforce and medicines efficiencies. And the Chief Pharmaceutical Officer role is an established leadership role. And within our Department of Health, it has been in place for over 30 years. And a very important part of my job is to work with the other chief professional officers, such as the chief medical officer and chief nursing officer. And we work very collaboratively to consider how our professions can best engage and deliver on the priorities for our patients and population need and our health service.
Now, you recently gave the keynote address at the European Society for Clinical Pharmacy annual symposium, and you described how clinical pharmacy is making a meaningful contribution to health and social care services, and you offered some insights as to how this had been achieved in Northern Ireland. And this is what I'd like to explore in a bit more detail. But first, could you give us a bit of background information, the policy context, if you will?
So in terms of context, I think, first of all, I would say I think Northern Ireland is probably similar to a lot of other countries across the UK and European, and maybe further afield as well today. So we are experiencing a demand for medicines that is rising, and that is related to our increasing and aging population. And we also have persistent health inequalities here in Northern Ireland. We have medicines costs that are rising annually and represent actually our second highest costs in our health and social care economy after staff salaries. And we also are benefiting from enormous advances in medical practice and in pharmaceuticals, but that is coming with a high cost and quite a burden for our health service in relation to implementation. We also know, and we are experiencing I suppose, the downside of high medicines use, and that is that we know high medicines use is associated with an increased risk of avoidable harm and also adverse outcomes for our population. And we also know that, and I suppose we have an increase in awareness that medicines are now also make up 25% of our carbon footprint within our health and social care system, and that our medicines waste is becoming a lot more awareness of the difficulties around that and the negative effect it has on the environment. Now, really, to close off that in terms of the broad policy context, although we have tried and tested practices in place in relation to patient safety and also cost effectiveness, the challenges are growing and continue. And so that we do need to keep a strong focus on those areas and how pharmacy can contribute to it.
So what does this mean for clinical pharmacy?
I would say that we have been on a bit of a journey in Northern Ireland over the last 8 years, and that is after some work that we undertook around 2016 to really understand our challenges around medicines, and that led to the development of a new strategy that we called our Medicines Optimization Quality Framework. And that strategy, for the first time, really looked at how we use medicines, what our challenges are, and also it identified as one of our key challenges the high level of variance in how medicines were used across our system and how we needed to move to more standardized ways of practice. And for the first time in that strategy, we actually describe what a patient can expect when they have medicines included in their care in the key healthcare settings of hospital, general practice, community pharmacy, and in care homes. And that really, I suppose, for the first time as well, allowed us to think about how would we affect change across a whole system and how pharmacy could contribute to that, and in particular, how we could translate our already quite strong evidence, even then to 8 years ago, of clinical pharmacy practice in hospital across a system.
Mm, mm. There must have been more to this, other developments to support what you were doing. So, what sort of things were going on in the background?
Over the last 8 years, we've had a number of huge sort of reform programs going on to support that strategy. And one of the most important one was in relation to workforce. Because when we started to look at our workforce, and this would probably have been around 6 or 7 years ago, we were in a position that we did not have sufficient pharmacists in our workforce to deliver either our current levels of care or certainly to deliver on our ambition in relation to medicines optimization. And that led to the development of a new pharmacy workforce review. And some of the key challenges that we had to address there very quickly were that reports at that time that our interest from our university applications for pharmacy, for example, were down. There was a lot of competition at that time for pharmacists, budding pharmacists and many of our young science students were going into IT at that time and had moved away from health, for example. And we also had no significant clinical pharmacy practice outside of hospitals at that time. So that led to our development and publication of a pharmacy workforce review that we did in 2020. And that allowed us to really focus on a number of big areas of work. And the first thing we did was we focused on attract, recruit, retain, which is really around increasing the capacity in our workforce, a dedicated attempt to reach out to schools to promote pharmacy as a very good career, and also invest more into the training programs for our existing pharmacists to upskill more independent prescribers, and also think about advanced practice and how that would be developed, as well as consultant pharmacists. And in addition to that, to invest in new roles in general practice and also in consultant pharmacist roles in hospital, and to begin to develop more clinical services in community pharmacy.
Mm. And did these pharmacy workforce developments also have implications for education and training?
There was also a big focus on reforming our undergraduate degree and our foundation year. So the first 5 years of pharmacist training. And that has to introduce much more clinical training into our undergraduate degrees, and also to embed independent prescribing into our foundation year training. So that sort of hopefully sets a bit of the policy context in terms of the macro level, and also then what we did in relation to medicines optimization and how that translated into clinical pharmacy.